Welcome to Brain Ponderings, coming to you today from the Netherlands by way of Maryland, where I'm at. So I have two guests today, Professor Antoinette Masson-van Brink and Rolf Fronczek. They're both from the Netherlands, but at different universities, medical centers there. And they're both experts on headache, and one particularly focuses on Dr. Masson-van Brink on migraine, and Rolf, he focuses on cluster headaches. And so obviously these are big problems. Probably most of the viewers and listeners know of someone that has migraines because they're actually, it's not uncommon. Cluster headaches is a little less common, I guess. And so I'm going to have them talk about what's known about what's going on to cause these painful syndromes, and then what can be done. So welcome, both of you.
Thank you.
Thank you.
So Antoinette, can you give a little background on what led you to become interested in headache? I know usually in science it's like a long road that has some twists and turns, and often we don't start out, we end up doing something we didn't initially think about, but so.
Yeah. In my case, I think I'm a little bit an exception because already during my master's work, I studied in Leiden, where Rolf works. I was working in the Department of Clinical Neurophysiology and looking at brain excitability with transcranial magnetic stimulation. And one of the projects I worked on was brain excitability in migraine patients.
Oh.
And yeah, then I started reading more about the disease, understanding more about the disease. And I was really intrigued by migraine because it's so interesting in its pathophysiology, and also there's still an unmet burden. So yeah, already as a master student, which is now quite long ago, I was really intrigued by it, and I was able to do my PhD in Rotterdam at Erasmus University, where I'm now, on migraine, and then more from the pharmacology side, looking at side effects of anti-migraine drug. And ever since then, I've stayed in this field.
And you mentioned before we went online that you're involved in organizing an international conference, European Headache Congress.
Yeah,
can you talk a little bit about that?
Yeah, so I'm, after all this year in migraine, I'm now professor of neurovascular pharmacology at the Erasmus Medical Center. But besides, I'm president of the European Headache Federation. And the European Headache Federation is organizing Congress, and I'm conference chair in 2 months' time in Rotterdam from 4 to 7 December. And we will have there a scientific program and also a patients track organized by the EMHA, which is the European Patients Organization. So very excited about that. And I hope we will have many participants, not only from Europe, but also globally.
And is that a headache to organize that conference?
It's not a headache. It's really a major job. It's quite demanding, but it's very nice, and it's great to be able to collaborate with nice people on organizing this congress and to have an influence on what's in the program and not. It forces you to think very critically, because we all do our own research. But if you are forced to think, okay, in the whole field, what are the developments now and what should be discussed, it's quite a challenging question.
Okay, and then Rolf, so what's your background?
Well, so I'm a neurologist by training, and I studied and did my specialty training for neurology in Leiden. I also did my PhD there, but then I chose a little bit of a detour because I'm also a somnologist, so a sleep neurologist, and I did my PhD in narcolepsy, sleeping disorder, and the hypothalamus, and the role of the hypocretin system that's involved in narcolepsy. But then I got back in Leiden again as a neurologist, where I'm now, because yeah, actually I have migraine myself, so I was always interested in migraine a lot, but then I stumbled upon a cluster headache because of the relation with sleep, because in fact the part of the brain that I normally use to studying in narcolepsy is also probably, maybe, that's a theory, it might be involved in cluster headache. And there's a huge relationship between cluster headache and sleep. So that's how I got into cluster headache again. But I do work at the headache outpatient clinic, and which I see a lot of patients, not only cluster headache, also migraine, and I also supervise with others. I supervise that clinic. So in fact, I see a lot of migraine patients, but that's more common, of course, than cluster headache. But my research focus is on cluster headache and sleep.
And so narcolepsy, I recall, so this was maybe, I don't know how long ago, wasn't there some role for dogs in discovering
Yes, that's
narcolepsy?
true. Yeah. The cause of narcolepsy, now we know it's caused by deficiency of a neuropeptide, and that neuropeptide is called hypocretin or orexin. It's the same thing. It's locally produced in the lateral hypothalamus, and but it was actually found through these dogs that this was true, because in these dogs they found a receptor mutation, and they didn't know what the receptor was for. And then they discovered, hey, this receptor is for this newly discovered neuropeptide hypocretin. And then they looked in humans, and then they saw that the receptor is functioning, but actually the peptide itself is gone, disappeared. And now we think it might be an autoimmune process targeting these neurons in hypothalamus. But that's still a topic for research that I also still do, but that doesn't have anything to do with headache.
Okay, so Antoinette, in the case of migraine, there's this, can you talk about essentially what the demographics are? You know, how common is it? Is there any difference between men and women? Is there any effect of ethnicity or and then like age of onset? I mean, there's a lot of questions. Yeah.
I will try to describe it concisely. I think it's important to realize that migraine is really a global problem, and differences between ethnicity are not that striking. The prevalence is about 12 to 15% lifetime prevalence. And yeah, if you calculate this to concrete numbers, it means that more than 1 billion people on Earth suffer from migraine. So it's really, really a lot. And if we look at the age of onset, it can start already during childhood, but most of the times, yeah, it gets more prevalent after puberty, when there are hormonal changes. And the prevalence again declines a little bit if you are middle-aged or further. So it's really a disorder that affects people in their fertile years. And that's a big contrast to many diseases that are more prevalent in aging people. And it really affects people when they're most active in their life. And many patients are taking care of young children, and they are taking of their parents, and still having the burden of migraine. And what you also mentioned, it's much more prevalent in women than in men, about threefold more prevalent in women. And in these women, its occurrence, the incidence of migraine attacks depends a lot on the menstrual cycle. And then it changes with pregnancy, and sometimes it gets worse during perimenopausal period. So it's really a disease where the hormones play an important role, and it affects many people.
And okay, and then Rolf, can you kind of say this, go through the same kind of demographics that in the case of cluster headache?
Sure. In contrast to migraine, actually cluster headache is much more common in males. That's really interesting. We don't know exactly why. There's a stereotype of the male cluster headache patients that often, if I see the waiting room, the outpatient clinic, I can say, oh, that's probably migraine, and that's cluster headache. Specific type of man, but that is a little bit old-fashioned maybe, because they used to say it's like 4 times as much in men compared to women. But now, recently it is newer data, maybe 3 to 1 or maybe even 2 to 1. So that is twice as much common in male compared to female. And so it seems like the incidence or the prevalence maybe in females is increasing, or maybe we diagnose it better, because I think in the past there have been a lot of confusion that people said, oh, it's a woman, so it must be migraine, and in fact it was cluster headache. But there's also a theory that it's more common now in females because there's a huge relationship with smoking. Almost all patients smoke, and because the difference in smoking behavior between men and women is becoming less different, so men and women are smoking at the same amount of cigarettes. So maybe that's why we see a more cluster headache in women. That's another theory, which is interesting. But in fact, so it's a more typically seen in males. And yeah, also, it's 1 in 1,000. That's the number you often hear. So the lifetime prevalence is 1 in 1,000. So it's less common than migraine, but still not that uncommon. And then there are 2 forms of cluster headache. The episodic form, where patients have attacks only during a few weeks or months in the year, and then they disappear again, the attacks. And often this is in spring or in autumn, and sometimes it skips a year. So that's the most common form of cluster headache. But 10% of the people have the chronic form, where you have attacks all the time throughout the year with a maximum break of 3 months. And that's the most.
And Rolf, when you say attacks, does that mean continuous headache, like 24/7, or?
No, it's a good question, because often when you say chronic, it seems like it's always, but that's not what I mean. Cluster headache attacks are a lot shorter than migraine attacks, so they last 15 minutes to 3 hours, mostly 1 or 2 hours, and they can occur like up to 8 times a day. That's also different compared to migraine. So they can strike many times a day, especially at night, as I said, especially during sleep, and also at predictable clock times often, and then in certain periods of time in the year, which makes it a very intriguing disorder. And also the pain itself, well, it's a little bit similar to migraine that we speak about pathophysiology later, I think, but they say cluster headache is the worst pain a man can have. It's always difficult to judge what's the worst pain you can have. But cluster headache is very extreme. It's like a stabbing pain, like somebody stabbing you with a knife in the eye, or toothache of the eye. And it's always at the same site normally, and most often it's the same site in people that have it. And it's an extreme pain where there's also a red eye, tearing of the eye. We call that autonomic features, or ptosis, or small pupil. So on the side of the headache, you also see clear autonomic features, which can happen in migraine, but not that severe, not as severe as in cluster headache. So that's a difference with migraine. And of course, there are other differences, but those are and maybe another then, but then I stop talking now, is that during a migraine attack, normally, like Antoinette said, there's some kind of excitability going on, and also patients have problems with this, like light or smells or sounds, or photophobia, photophonia, osmophobia. So when you have a migraine attack, and I know this, when I have it, you want to be in a bed in the dark without anything, just nothing.
Yeah.
But people with cluster headache during the attacks, there is a lot of restlessness and the urge to move. So people with cluster headache, they move around, they walk, they bump their heads against the wall. They just cannot be quiet, silent. They cannot keep silent because it hurts so much, and they need to do this. That is a huge urge. It's also in the criteria for the disorder. I even have one female patient, and when she has an attack, she puts on headphones and death metal music. Well, if you have migraine, you don't want to have headphones on your head with death metal music. So you really listen to patients, also to women that have these attacks. For me, it would be very easy to make the diagnosis, but I think in the past, often this went wrong when there was not enough time to listen.
Yeah, and it's interesting what you say, Rolf, about these stereotypes, because in cluster, maybe the sex ratio was overestimated, and now even in migraine, there are debates going on whether we are underdiagnosing migraine in men, because maybe, the description, the diagnosis of the disease depends on the anamnesis and what the patient is telling. And maybe the whole picture for cluster was too much focused on the men, and for migraine too much on women. But having said this, I really want to stress that the female component and female hormone changes are very, very relevant, and should not be underestimated. But there's now a lot of discussion about these topics.
Yeah, indeed, yeah.
Okay, so with migraine, Antoinette, can you talk a little bit about, I guess it's been known for a long time that there's like vasodilation of blood vessels, right? And that is somehow linked to the pain. So what's going on there? What's known about what's
Yeah, Rolf is already smiling because it's a matter of a lot of debate.
Oh, okay.
The classical view was always that, during a migraine attack, after initial changes that are in the brain, and there may be even vasoconstriction involved, that finally there's a vasodilation in the dura mater outside of the brain, and this vasodilation would lead to the headache. Then it has been debated for many, many years, and it was considered very, very old-fashioned to even think about blood vessels. And I think
I'm the oldest one on this podcast, so
yeah,
that's why.
but I told you that I already started researching migraine in kindergarten, so I have also experienced quite some period. But then I think now we have reached a more nuanced view, agreeing that migraine is a neurovascular disorder. Yeah, of course, the brain plays an important role, but also neurons outside of the brain, and probably there are vascular changes, and whether these vascular changes are really responsible for the headache or are an epiphenomenon related to activation of the trigeminal ganglion that is located outside the blood-brain barrier, so a little bit peripheral, that is still a matter of debate. But in fact, the migraine attack most likely starts in the brain. There are a lot of changes. In about 1/3 of migraine attacks, you see spreading depolarization of the brain that leads to the clinical perception of aura, which is often visual, but can also have other sensory qualities. And that is followed in the vast majority of migraine patients, not always, but very often, by the characteristic headache. And we know that a headache can be treated by drugs that do not enter the brain, because maybe you want to talk about it now or later, but there's a class of drugs that does not enter the brain and is still effective in the treatment of migraine. So these novel drugs with different characteristics teach us a lot about the pathophysiology of the disorder.
Yeah, so Rolf mentioned a peptide hypocretin and its role in the hypothalamus and controlling sleep. And in migraine, there's another neuropeptide that seems to be involved. So maybe it would be a good time. Why don't you talk about CGRP, Antoinette, and then maybe Rolf, I had a question about, because the way you framed it, this hypocretin is produced in hypothalamic neurons, but if it's playing a role, is it? I don't know. But if it is, then are these neurons, hypocretin neurons, like extending axons to other regions? And so I guess talk about the neuropeptide connections.
And we will go first.
Which peptide do we talk about first?
That's up to you.
Or maybe I can be shorter about my part, because I think we'll talk about CGRP a lot more in relation to headache.
Okay.
Because,
Go ahead, Rolf.
yeah, hypocretin or orexin, it's not officially yet linked in a scientifically proven way to migraine or cluster headache, although there is a lot of talk about it. Maybe also using this system as a treatment, people have tried. And there are lots of effects on pain of hypocretin, but it's all still science. But we know that hypocretin projects throughout the brain, not to the cerebellum, but to all other parts of the brain. It does have strong projections because it's one of the key players in keeping us awake and causing sleep-wake balance. So it's connected with a lot. And it's also, and there are two receptors for hypocretin, and one is very much linked to pain and pain behavior. So it might be that in the future we will use this system, maybe for treatments for pain, and also maybe for rhythmicity in these disorders, but that's still very,
Okay.
we don't know yet. So I think CGRP, there's a lot more to say about CGRP nowadays in relation to actually both cluster headache and migraine, but more so for migraine. So now Antoinette can talk about CGRP.
Okay, do you have some time? It's CGRP is an abbreviation for calcitonin gene-related peptide, and I will keep it short. It's a peptide of 37 amino acids. In fact, there are two forms that are encoded by different genes. There's alpha CGRP, which is most predominant in the nervous system, but also beta CGRP coming from another gene. And it's most active in the enteric nervous system. But now it seems that they are both in several places in the body. So we cannot say that migraine, just alpha CGRP is important. And interestingly enough, although they are encoded by two different genes, there are only 3 amino acids different, and their pharmacology is very, very similar. But I think that there are, subtle differences that may be important in understanding what's going on and why drugs work in some people and not in other. So we know already from the beginning of the 90s from studies from Lars Edwinson and Peter Goadsby, who were really pioneering in this field, that CGRP increases during a migraine attack. And they couldn't measure it just measuring from the cubital vein, because CGRP has a short half-life in the body and it gets diluted. So they take jugular blood samples, and then they showed it was increased. And after remission of the migraine attack with the anti-migraine drug sumatriptan, then the levels were normalized again. So that was an indication that it was involved. Then in Copenhagen, there's a group where they are able to infuse CGRP, and they showed that it could trigger migraine-like attacks in migraine patients and not in healthy volunteers. So it was a second clue. And that led to the development of drugs that inhibit the action of CGRP. And the first that were coming were small molecule receptor antagonists called gepants. And they were effective, but didn't reach the market for reasons of pharmacokinetics. One could just be delivered intravenously, which is inconvenient. And the other one caused liver toxicity at high dosages. And then some other gepants showed the same liver problems. So then it was thought it was a class effect. And then antibodies were developed either during against the CGRP receptor, we have one of these, or acting at the peptide itself, the ligand. And we have 3 antibodies, so these are now available. And after all these years, other CGRP receptor antagonists, small molecules, so more gepants were developed, and we have now 4 of these available. So suddenly quite a large armamentarium acting at CGRP itself or the CGRP receptor. So that's a game changer.
So if you give the CRGP antibody intravenously, it's obviously going to sop up the CGRP in the blood, but so I guess that means that circulating CRGP is somehow promoting the pain in migraine.
CGRP is not thought to act like a circulating hormone. And of these antibodies, only one is delivered intravenously. The other 3 are delivered via subcutaneous injection, but ultimately they reach the circulation, of course. But it's not so much CGRP that is circulating. It's more likely that CGRP that is released during a migraine attack, really at the neurovascular junction, that plays a role. And it's more that the antibody is already circulating, or in the case of the receptor blocking drugs, they are already blocking the receptor. And when CGRP is released, it's either wiped away instantaneously or the receptor is blocked for the other drugs.
Right. So the antibody doesn't cross the blood-brain barrier. Does CGRP cross the blood-brain barrier?
Also not, it's a peptide.
Okay, so
but it can be released outside the brain, but it can also be released inside the brain.
Right, but so you have the neurovascular unit and this is actually how functional magnetic resonance imaging works, where you look at neural network activity. You're actually looking at blood flow, right? And So there's this coupling of the neuronal activity to blood flow. The more activity in the neurons, then there's increased blood flow, then you get more nutrients to support the neurons. And then, but there's this intervening cell, the glial cell, the astrocytes, right?
Mm-hmm.
And then you've got the blood vascular cells, whatever, parasites. So I'm just trying to figure out, you know, if the antibody doesn't cross the blood-brain barrier, and you think that CGRP is being blocked by the antibody. So I'm trying to figure
CGRP is released outside the blood-brain barrier. So that explains.
Isn't that consistent with a more vascular action than a central action?
Yeah, yeah. So
okay, so then that
I
comes back to the vasodilation or the blood flow hypothesis.
Yeah. No, I think at this stage we can certainly not rule out vasodilation. And as a neurovascular pharmacologist, I'm very fond of blood vessels. But also I already mentioned the trigeminal ganglion, which is located outside the blood-brain barrier. And its receptor profile is also quite similar to that in the blood vessels. So we should not forget about the ganglion as a target as well. But I'm sure that blood vessels are involved in the pathophysiology of migraine. And also, which is not widely known, is that migraine, especially migraine with aura, is a cardiovascular risk factor, similar to diabetes or smoking. And so it's very clear that blood vessels are relevant in migraine.
Okay, well, we'll come back to that,
Yeah.
the metabolic thing. Rolf, so CGRP, do the CGRP antibodies or antagonists have any benefit in cluster headache patients?
It's a difficult question. Unfortunately, it's not a big yes for now. If you go back to the beginning, like Antoinette, how she explained in migraine, the same can be said for cluster headache. So during a cluster headache attack, the concentration of CGRP is increased in the blood, measured in a jugular vein. And also experiments have been done that if you give infusions of CGRP to people with cluster headache during an active episode, so when they are in an attack period, then they can get attacks because of this infusion, so it can trigger attacks. So people thought, whoa, there's a link between, and if you treat cluster headache attacks, you can treat it with injections with triptans, the class that we will maybe speak about later. So the treatment for migraine, if you use it in subcutaneous administration or when you inhale oxygen, both things work for cluster headache attacks and reduce CGRP concentration. So there's this whole link between CGRP and attacks of cluster headache. So the expectation was that these new antibodies would actually work. And there is a huge unmet need in the treatment of cluster headache, mainly in chronic cluster headache. But now the story is complicated. There is only one positive trial in episodic cluster headache, where the unmet need is not as extreme, and there are other options. But well, the trial was positive in episodic cluster headache. But that's the only positive trial until now, and the FDA approved the use of these antibodies for episodic cluster headache, but the European equivalent, the EMA, they didn't. So in Europe, we cannot give it for episodic cluster headache, but in the United States, you can. But there are other options. And then we have chronic cluster headache, where the unmet need is huge, and there we really need a new treatment, and there all the trials up until now have been negative or stopped due to futility reasons. So it is no wonder drug that it works for all. But of course, there are always these clinical anecdotes of patients or trial subjects who say, well, it really worked wonderfully for me. Or doctors that say, well, but in my patients, I still gave it and it worked. So there are believers that still think it works. But on a group level and how the trials have been designed, some people say the trials were not designed well enough, but well, it's not a clear effect. Like if you give prednisone, corticosteroids orally, you can really remove all cluster headache attacks in the majority of patients. So that's a clear effect. And there are other things you can do for cluster headache which have clear effects. So if CGRP would be like that, if it would be a really key player for the trigeminal vascular network and activation and the attacks, like we think in migraine, if that would really be the key element of cluster headache attacks, it should have worked in a better way. That's my opinion, I think. But it's a little bit difficult because many patients want it. And we can prescribe it now for migraine. And if we say, no, we're not allowed to prescribe it for cluster headache, it's very expensive. And the trials have been negative. So that's the story now. But I think the book is not closed yet. And there are more trials ongoing. And maybe with a new class after this, which maybe Antoinette will speak about later, the renewal of the G-pens, maybe that for the future might work in cluster headache. I hope so. But at the moment, it's unfortunately not as hopeful as for migraine.
So you mentioned two treatments that work are beneficial for cluster headache and I guess one anyway for migraine. So you mentioned oxygen and you mentioned glucocorticoids, prednisone or cortisone or whatever. So that the latter brings up the issue of inflammation. The former, what's the mechanism for oxygen? Is that known as?
Well, it's not known. Some people thought it's just the cold air or the flow of the air, maybe some activation of the autonomic nervous system. There are theories, but actually we don't know why it works so well. But not in all patients. 50 to 60% of patients it works well. And in migraine, it doesn't really have this effect. So it seems to be quite specific for cluster headache. And while the sumatriptan injections work for both. So that's also interesting.
So during COVID, at least we did, we bought a pulse oximeter, right? So you can put this device on your finger, it's infrared, I guess, and it essentially getting an indirect measure of blood oxygen levels. So do patients with cluster headache is there any, during an attack, is there any change in their blood oxygen?
Yeah, it's not very clearly, but I must say there are not a lot of really good studies into this because there were reports of increased prevalence of sleep apnea syndrome in cluster headache, but that then was checked again in a better way with real measurements, and then it was really not more than in the normal community. And then there were some reports that if you treat sleep apnea with continuous positive airway pressure with a mask, that it would improve cluster headache, but that's only anecdotal. Again, not in a bigger study, not shown. But it's good anyway to screen for this if you think it might play a role. So, but if patients during an active episode take an airplane or they go skiing in the mountains, then they have a lot more attacks. So if there's a lower oxygen concentration in the air, I don't know if that's the correct
Pressure.
pressure. It's a pressure and not concentration. Sorry, the pressure. That seems to be able to lower the attack threshold. But it's not clearly that during an attack there's a decrease in oxygen in the blood when you measure it on the finger. But I think this might be studied better. I have sometimes wonder maybe I should start such a study to do more measurements during attacks because there's more to be discovered, I think.
Yeah. And so Antoinette, with so what about inflammation? And is there any role for inflammation?
Probably there is, but it's not quite clear how. And I think inflammation is now getting involved in nearly every disease.
Yeah.
And lots of research is going on, but I think it's too early to really say what the role is.
Okay. And I guess there's other patients, like with migraine, since it's fairly common, there are a lot of people now getting treated, like they have arthritis, for example, right? And there's undoubtedly a lot of people that have arthritis and migraine. And so a lot of people are getting treated like with antibodies against tumor necrosis factor, which is a kind of a classic pro-inflammatory cytokine. Is there any like epidemiological data on whether someone with arthritis that also has migraines, if when they get treated for the arthritis, it affects their migraine?
I'm not aware of any studies specifically reporting this. Arthritis is certainly not under the common comorbidities. And what's interesting, of course, drugs like NSAIDs are used in both conditions. And what's different if a migraine patient uses NSAIDs at a daily basis, there's the risk of medication overuse, which causes an increase in the frequency of migraine attacks.
Huh.
When someone without migraine, with arthritis, uses NSAIDs on a daily basis, this is not the case. These patients don't get headaches. So something should be primed already. And there are animal experiments also that have suggested a role for CGRP, for example, in arthritis. So there was also the question whether these antibodies would be effective against arthritis as well. And until now, it's negative. And of course, you may ask whether the antibody reaches the place within the joints where it's needed. But there are quite some differences. So it's not just more of the same. I think there are probably similarities, but also lots of differences.
Yeah, so you mentioned animals. So I guess these headache syndromes are something that it's, I don't know, very difficult to model in rats or mice. So that brings up the question of genetics, at least in my mind, because we did a lot of work on Alzheimer's, Parkinson's, for example, where there are gene mutations that they're causal. They cause the disease, and then you can put the mutant human gene in a mouse and see like amyloid accumulation in their brain, or degeneration of dopaminergic neurons in the Parkinson model. So I guess there's really nothing. I mean, how do you?
I wouldn't say there's nothing.
There's not. Okay.
There's a specific form of migraine. It's called familial hemiplegic migraine. So it's a form of migraine where even hemiplegia is part of the attack. And already since the end of the 90s, there has been a discovery of genes. The first was calcium channel gene, and then a sodium potassium ATPase was found, and as a third form, sodium channel. And of course, it was the hope that if these genes would be further followed, this familial hemiplegic migraine is autosomal dominant. So yeah, the inheritance is very clear. If you would study these genes in the more common forms of migraine, that it would lead to a solution. And that unfortunately was not the case. And of course, now we have the GWAS era where in enormous cohorts that were formed by consortia, genes have been studied. And then there are about 180 hits that are consistently present for migraine. And but their individual contribution is very, very limited. So they are significantly linked to the disorder, but it's not that, you can pick one and develop a drug and that's the solution. And if you look at these genes, they are active for one part from the pain networks and also from vascular networks. So it's understandable where these genes come from, but it has not yet provided a solution. Having said this, I think there are transgenic mice expressing these genes from FHM, and they have been quite useful in understanding parts of the migraine pathophysiology. And for the rest, there's not one model that really mimics all aspects of migraine, but there are lots of animal models that are really providing relevant information. But you should also always ask the question, what aspect of migraine am I modeling? So it can be either cortical spreading depression, we use rodents for that, or the CGRP release in the dura mater, that's possible in rodents. We are now doing cardiovascular studies. We are using pigs for that because that resembles the human cardiovascular system better. So it's always one aspect of the whole scala of a migraine episodes that can be modeled with animal experiments. But I think it's fair to say that this has really led to the development of effective drugs. And
Okay.
it
Yeah.
would be nice to live without animal experiments, but unfortunately we are not there yet.
Okay, so a couple other things. One thing that hasn't been mentioned is serotonin, and I see there is some role maybe for serotonin in headache.
Yeah, that of course is an old story, and the background of the development of the triptans that are now the golden standard for the acute treatment of migraine attacks. And it was found that infusion of serotonin, could be effective in aborting a migraine attack, but serotonin is a ligand that stimulates 14 different types of serotonin receptors, and not every effect is desirable. So there was a search that, Pat Humphrey from the UK has been very, very prominent in. Also my mentor, Professor Saxena, was active in this, and that finally led to more selective agonist, first 5-CT instead of 5-HT. And then finally the molecule of sumatriptan was developed that's only stimulate a few of these 14 serotonin receptors. So that was an enormous step forward.
And so when the general public, as much as they, or little maybe as they tend to know about serotonin, it's usually been in the context of antidepressants and psychedelics, right? And so do antidepressants have any benefit? I mean, the ones that are used for depression or anxiety disorders, do they have benefit?
Maybe I can, because we do a lot of treatment, of course, not only with CGRP antibodies. We also use other drugs. We call it prophylaxis to prevent attacks. And some of those, the majority actually is either beta blocker, so it works on the vessels again, or candesartan, also in the blood vessels. Then we have the antiepileptics like topiramate, valproic acid. So they inhibit neuronal firing, you can say. They influence these ion channels that were mentioned before for the animal models. But there are also, like amitriptyline is an antidepressant, but has many other effects. It's one of the old-fashioned antidepressants that is used in the treatment of migraine. But other antidepressants, it's not that in general all antidepressants have beneficial effects in migraine, but not all have been studied very well. But yeah, there are a few that are actually used. It also is a little bit different in different countries, so between the US and Europe, I think. So we do use them in the treatment of migraine, but they're often not first choice. And but there are in the list of the drugs that we previously had and we still use for the treatment of migraine before the CGRP era. It's also interesting what you said about illicit drugs, because in migraine it's less common, but in cluster headache, it's like the stereotype we talked about. Many of the patients smoke, but they don't only smoke, they also use illicit drugs. Even before the onset of the disease, but many of them try it after they have the disease to prevent attacks. And actually, many patients report that drugs working on serotonin system, but also like LSD or psilocybin, that they might actually have a very good effect to prevent attacks or even prevent the complete episode with attacks. It's anecdotal, but it's very consistent all over the world. And there are actually some studies now started to look at this, if it's really true. So microdosing LSD or microdosing psilocybin. So in Holland, it's also planned in the Netherlands to start such a study with microdosing LSD. So I'm looking forward to seeing the results and to see what maybe it helps us. But it makes sense because many of these drugs, they act upon the same serotonin receptors that Antoinette just mentioned. And sometimes we even use long-acting triptans in the treatment of cluster headache. And sometimes I think that we're maybe doing the same thing as microdosing psilocybin or just giving a very long-acting triptan, because they work generally on the same receptors. And also ergotamine, that's the old-fashioned drug, that works on a lot of these receptors, also as from the same class as also. So the compound resembles these illicit drugs a little bit. So maybe we're all doing a little bit of the same thing with the same type of receptors, just in another way. But it's very common in cluster headache patients to use these drugs. Yeah, it's interesting.
Could you two talk about a little bit about the functional brain imaging? Antoinette mentioned spreading depression, and there's been a lot of work done, right, with psychedelics, looking at what's happening in different brain regions, which circuits are changes. So what's known there for both for migraine and clusters?
I think, Rolf, it's nice if you tell about it.
Okay.
Yeah.
But yeah, he's the neurologist.
For cluster headache, people have looked at hypothalamus, again, because of this clear relationship with sleep and clock rhythms. And it's a little bit difficult to interpret because in one older study, a larger part of the hypothalamus was found. But as a sleep researcher, I know that if you look under the microscope, the hypothalamus has many different cell areas, cell groups. So if you say it is larger in general, what does it mean? Well, that has been found. And also during attacks, activation with fMRI has been found of the hypothalamus. But the difficulty is, is it just cause or consequence, epiphenomenon? Is the reaction to pain? It's very easy to incorporate it in hypothalamus story to make it in a nicer story. It's often, like especially clinical doctors, we like to tell a story. So if it fits within the story, people remember it. But I'm not. The thing is, during the attacks, there's a huge activation of the trigeminal vascular network with these autonomic features, always on the same side, but it can switch sides. We do local treatments now with injections or neurostimulation. And when you do that on one side, the attacks can switch to the other side. So if you then talk about brain imaging and you look for changes and it can shift to the other side, it must be functional changes, not structural changes. Because that was the thinking in the past, that would be structural changes like this, the cavernous sinus would be too much pressure or too big or too small, or there would be something going on there in the trajectory of the autonomic nervous system and the nerves involved in that. But yeah, if it can switch sides, it's not like that probably. So things have been found pointing towards the hypothalamus. That's the story for cluster headache, and we don't know for sure. For migraine.
So for the stimulation, do you stimulate the trigeminal nerve or the vagus or what?
Yeah, for cluster headache, it seems to be like whatever you stimulate, it works. I was very skeptical at first, but I see the effect now in clinical practice. Now, I think if you would stimulate the trigeminal nerve, but how to do that? The most easy access point is on the back of the head with the greater occipital nerve, because in the cervical complex, it's connected to the trigeminal network. So most often we do injections with corticosteroids, or we use electricity with a neurostimulation device on the occipital nerve, both sides now, because otherwise it jumps to the other side. But you can also do it in the sphenopalatine ganglion. So then it's more complicated to reach, but also possible. But now there are also plans to look at the supraorbital nerve to stimulate that. So just stimulating.
So if you have a patient that's having the headache on one side, and is what you just said, did I interpret it right, that then you stimulate on that side, the pain goes to the other side?
Well, if you inject corticosteroids in one side in a certain percentage, like 5% of patients, it can jump to the other side. But for the corticosteroids, we do it on the side of the attacks, because for most people that's sufficient. But if you put electricity on the nerve, like continuous, that's what the neuromodulation devices do, then there is a lot larger proportion of patients where it jumped to the other side. So that's why nowadays we stimulate at both sides with electricity. And that works in many cases, also in the very difficult to treat chronic cases. That's where we actually do it because it's very invasive and costly. So that's the newest treatment for cluster headache. It's occipital nerve stimulation. But luckily for many.
So you're implanting. You're actually it's not just a surface electrode. You're implanting an electrode in. Yeah.
So that's for the most severe cases. And for the, if you want to have a short-term effect, you can inject corticosteroids. And maybe new devices will come. There are many people now working on those devices because it works, surprisingly, it works well in cluster headache. And there are also studies in migraine, as a matter of fact, because there are some reports that they might work in migraine. And I know in the US it's a lot more popular than Europe, but we are very skeptical in Europe and we don't like all these invasive things. But I know in the US there are many more devices for migraine on the market that stimulate all kinds of nerves. And who knows, well-performed studies are underway. And for the future, who knows? But you also asked about the brain imaging in migraine, because it's also interesting. Professor May in Germany, that's one of the most famous studies, followed one single patient and scanned every day, and then saw where the first activity started to see where does migraine start. Because as Antoinette said, because of the animal models, we know about the migraine attack, we know many phases of the attack and what happens, but we don't know why does this person have an attack at this time point? Why does this person even have migraine and not the other person? So they looked at the first brain area where it started, and that was in the brainstem in the pons. But then again, you might think, what does it mean? And why does it start there? And how can we link this to the whole story about the blood vessels and the CGRP that is released between the trigeminal nerve and the blood vessels? And why does blocking it peripherally work while the attack initiator is in the brainstem? So it's still very complicated. But because that's the whole point for cluster headache and migraine. We don't know the true cause yet. We know many things that happen during the attacks, but the actual cause, to treat it in a causal fashion, that we still don't know for both disorders.
So let's finish up by talking about like lifestyle factors or environmental influences. And maybe Antoinette, I was very interested in you had a paper on links between metabolism, insulin resistance, for example, or diabetes, obesity, and migraine. Can you talk a little bit about that?
Yeah. First of all, I think it's a very tricky topic, because if you start talking about lifestyle, then you encourage patients to take the direction of their life in their own hands, which is empowering. But on the other hand, and I will talk about it a little bit more, the short answer is that we don't understand exactly what's going on. So if you tell patients, and of course for everyone it's good to exercise and not to smoke and to eat healthy, but if you would be too specific, because there's always, especially on the internet, someone who claims that a certain diet is fantastic and it's the ultimate cure for their migraines, it will lead to many restrictions for individual patients. And the bad side of the coin is that if you are still suffering from migraine, then yourself or the people around you can get the feeling that then it's you to blame, because you should not have eaten this, or you should not have gone to this party. And I think that is certainly not the direction I want to advocate, because it's a neurovascular disorder, it's a brain disease. We were discussing the imaging, it starts in the brain, and it's not someone's own fault. But of course, I'm very interested in the topic, and we know, for example, chronification of migraine is related to obesity. But with diabetes, there's an inverse relationship between diabetes and obesity and migraine. But obesity and diabetes are again linked. And then it's, of course, the question, is it type 1 or is it type 2? And we have now very exciting results from our own department, where we look at a link between preeclampsia and migraine. Again, there's comorbidity, but there are differences in its profile. And one study that I performed together with Professor Tobias Kurt from Charité in Berlin, Germany, I was so intrigued by our findings, because we looked at patients that had migraine in the past and patients with still current migraine, and migraine that developed only after start of the study. And what we found is that the Framingham risk score, which is a traditional risk score looking at lipids, cholesterol, the blood pressure, the traditional cardiovascular risk factors, it was much higher in patients who had a history of migraine, so who had migraine in the past, but not anymore, compared to subjects without migraine, but it was lower in patients who only developed migraine later in life. So that teaches us that there is really a connection between all those factors, but at the same time, it's a lesson to be humble, because yeah, we don't understand what's going on, and it really asks for further research that we are of course doing. And we know that migraine, I already mentioned earlier, it is a risk factor for cardiovascular disease, not just stroke, it's not all in the head, but also it increases the risk for myocardial infarction. On the other hand, if you look at arterial calcifications, which are a very obvious indicator for vascular disease, then these calcifications are lower in patients with migraine than in patients without migraine. So they have increased vascular risk, but probably this risk is not mediated by the common pathways that we know. And yeah,
Do they have increased risk of clotting, blood clotting?
not necessarily what we think, but many more research has to be performed, that it's a microvascular problem. And we have shown in women with migraine now that their microvascular function, and we split it up with a complicated protocol that we could distinguish between the role of nitric oxide in microvascular responses. It's a vasodilator, but also the innervation by neuropeptides. And what we now think, but what we need to work on further, is that the microvascular innervation in migraine patients, but then I'm not talking about the head, but also about the forearm, where we did our studies. Yeah, the innervation is a little bit different by neuropeptides. So we come back again on the neuropeptides. So there is something going on, and I definitely believe that metabolic factors play an important role. But it's not as easy as one would think at first sight. There is an increased vascular risk for both stroke and myocardial infarction, but it's not mediated by the traditional cardiovascular risk factors as we know them.
Huh, interesting.
And maybe on a practical level, what you can say now to patients, because of course patients ask this all the time in the consultation room, like, should I do something with my lifestyle? I don't want all these drugs. Can you make some recommendations? And then there's not evidence-based, so it's very difficult, because many patients say many things, and also when you read on the internet, even some physicians have peculiar advice, but a few things pop up all the time, and that's red wine. So alcohol and specifically wine as a trigger. That's very interesting and still not proven, but there might be something into that. But still, I would not advise patients to never drink again. Well, we should advise all people, of course, not to drink alcohol and not smoke, but well, okay. But another thing, because I also work in a sleep center, and I think for everybody this would be good advice to have a regular sleep pattern. But if you go to bed at the same time every day, very boring, and also wake up at the same time, also in the weekend, this is good for many things, but also for migraine. There have been several studies now, mainly diary studies and patient-reported, but that show that if you sleep longer or shorter than you normally do, so if you change your sleep pattern, you have a higher chance of getting an attack. So if people really want to have some advice that they can already use nowadays, say, well, a regular sleep pattern, I think that helps. And it's also my own experience. But of course, it's much more complicated. It's not so simple. And I don't know anyone that treated their own migraine by becoming like a Buddhist monk lifestyle and do everything perfect. You will still have your attacks. You still have the brain disorder, I think. So it's not easy to only lose lifestyle.
The same as with these diets. It's very good, of course, to have a good sleep hygiene and to have your life regulated well, but it should not be a stringent harness that you live in so that you can't enjoy life anymore. And yeah, I think for the cardiovascular risk, we don't know how it's mediated, but of course, you know, as a migraine patient that your cardiovascular risk is already increased. So reason the more, although we should all pay attention to it, to have a healthy lifestyle, don't get obese, eat healthy, the things everyone should do, not smoke.
What about physical exercise?
I think it's again the same. It's not a cure against migraine, but of course, exercising is good for everyone.
Some people, it can trigger their migraine, so then have to be careful with too much exercise again.
And okay, we're good. There's so many things. So what about hydration state then? If someone becomes dehydrated, are they more or less likely to have an attack?
Hangover. Because that's the whole story about the hangover as well. Eh? So what is a hangover
Ah,
headache? Is it the alcohol? Is it dehydration?
ah,
And many patients also have migraine. People with migraine are also more likely to get a migraine attack in such a situation when they have a hangover.
ah,
And
yeah,
some treatments might even, maybe, it's difficult to say, might have some beneficial effect on this headache. But I think many patients that are likely to get, so migraine patients, many things can trigger an attack, maybe can trigger an attack. But you have to be careful with all these things because we also always look for causes. So every time you have an attack, I also do that myself. Every time I have a migraine attack, I think, what did I do wrong? What
yeah,
happened? Why do I have this attack now? And then
yeah,
you can say, oh, I was dehydrated, or I
yeah,
drank this, I ate chocolate, I didn't sleep well enough. Maybe this change in sleep pattern are because of the attack already. Yeah, the prodromal phase can also be an explanation that your sleep is not so restful, disturbed because you're about to get the attack. So there are many. So you have to be careful. Like Antoinette said, patients shouldn't have the message that it's their own fault and that they have their attacks because of their lifestyle or because they didn't drink enough water.
yeah.
But on the other hand, I do think that for some, also in my own experience, when it's a very hot day and you don't drink a lot, I'm very likely to get a migraine attack. That's my own personal experience, but there are not a lot of scientific studies.
You know, I used to get headache, and I don't know if migraines or cluster, but I used to get headaches on like hot days, being out in the sun,
Yeah.
bright sunlight for extended time. I think that's a common trigger just for headaches, but not migraines or cluster. What about international travel? So you mentioned, disrupted sleep patterns. Are people more likely to get a migraine attack when they're doing international travel?
I know that people with cluster headache in an episode, then they can have a lot more attacks when they go by airplane and also when they change time zones and sleep patterns, or when they have night shifts, the same when they work at night.
Yeah.
With cluster headache, that's a standard advice to be careful with that during episodes, but not outside of episodes. But for migraine, I don't know. Yeah,
Yeah, there's some research on the melatonin and migraine, so there may be something. But again, I think patients know on their own individual level when something is a real trigger or not, and we should be careful not to restrict patients too much. And in that respect, I think it's very important, Rolf was already mentioning that before the headache phase of a migraine episode starts, there's the prodromal phase, where maybe there is a change in perception. And there may be a disturbed sleep pattern, or stress may be perceived as much more severe than it would normally be perceived. So then patients report a link, but the stress was not more, but the perception of the stress. And the same for food. There may be a craving for food, for certain foods. And I often make the analogy for many women before their menstrual period, they also get craving for food. And there's no woman on earth, I think, who said, I ate a bar of chocolate and now I have a vaginal bleeding. It's because of the chocolate, because we know it's a cycle of 4 weeks that goes on. But for migraine patients, in some reason, there may also be the same craving, and then a patient eats this chocolate or something else and gets the migraine attack.
Yeah.
And it's easy to make a causal relationship, but maybe there's not.
Now that last thing, so smoking, you said, Rolf, that smoking is a big risk factor. And is it the nicotine? So do people who do vaping instead of cigarettes, the same thing?
Who knows? The association, like if you just ask patients, do you smoke now? Did you smoke in the past? For cluster headache, it's extremely high, like almost all of them. It's surprising when they did not. And also the newest, like we talk about genetics in migraine, but also there are genetic studies in cluster headache, and there are a lot less of these loci found. There are like 4 or 5 really strong ones. So a lot less than migraine, but still it's not directly inheritable cluster headache, but genetics play a role. And I was surprised actually when you look at those loci and which genes might be involved. I was expecting genes related to sleep and the clock and pain, but what actually the genes that were mainly involved were blood vessels again, and also some with the lung and something with neurons, which makes sense. And then they did Mendelian randomization, which is a very complicated genetic technique where you can look at causality. And they found that genes related to smoking behavior had like some causal relationship with cluster headache. So they concluded, and I'm also part of it, but it's a complicated story, but there was some kind of conclusion that smoking plays a causal role in the development of cluster headache, which is still a message to patients a little bit difficult, because if they stop smoking, it doesn't help. They still have the cluster headache, but maybe it helped to develop cluster headache because they smoked. But for cluster headache, it seems to be quite clear, and also why maybe more women get it nowadays compared to men, like the ratio, not the absolute numbers. But for migraine, I don't know, Antoinette, if you know, but I don't know lots of clear stories about smoking.
It depends from cohort to cohort whether there's similar smoking or less smoking. One of the theories that goes around, because sometimes you see decreased smoking, is that migraine patients avoid smoking. We know that cigarette smoke is an agonist at the TRPA1 channel, so it's one of the nociceptor channels. And yeah, TRP channels may release neuropeptides, so it all needs to be proven, but it's one of the theories that could connect cigarette smoking to migraine and possibly also cluster headache. But I think smoking has so many effects that are so widespread and so damaging that
So everybody knows about nicotine. So you're saying there's some chemicals in smoke that activate this calcium channel, the TRP
It's
channel?
not a calcium channel, it's a nociceptor, transient receptor potential channel A1, TRPA1.
I thought they are calcium channels, no?
No.
Okay. All right.
Yeah,
But-
sorry. Yeah. Calcium, yeah.
And isn't
Result
that
activation is
isn't that
calcium
what isn't that what
influx.
hot peppers, the capsaicin in hot peppers activate
Yeah.
certain TRP channels? Yeah.
That's TRPA1. Yeah.
Yeah. Okay, that's interesting. So we could be talking all day, right? So what
Yeah,
about
there's a lot to say about it. Yeah.
yeah, okay. Yeah, so is peppers, if you eat peppers, is that a trigger?
It has been investigated and it's more complicated than that.
Okay.
If you have the intake, it goes in the GI system. The TRPA1 channels are on the neurons, so it's in probably more local processes that are involved. But there's a lot still to research.
Okay, finally, what's the most exciting thing on the horizon for each of you in your research?
Well,
You first?
I can think well, yeah, like personally, because of my two hobbies, like headache and sleep, I'm very excited that now we're going to start a study where we try to treat cluster headache by giving certain narcolepsy medication that affects sleep. So that for me, that's personally very exciting to see if we can treat cluster headache by manipulating sleep. So that's one thing that I find interesting. But I think more broadly for cluster headache, I hope that there will be some new medications, some new compounds that will be found. And there are some targets maybe, but that's still the far, far future. But for the near future, I hope that neuromodulation will become available for more patients. It will become smaller, cheaper, because it's really a terrible disorder. And it's really, there's a huge unmet need, and the patients really need a better treatment, the chronic ones, and we don't have that yet.
Yeah.
So it can be very frustrating also as a physician that you really want to help them and you see them going down and down and down, and you try all the different things and all the medication with all the side effects. So for me, in the coming years, I really hope that neuromodulation will work better and be more available, and then maybe something with sleep.
Okay.
Okay, then my two things. I had
Yeah.
some time to think about it in
Yeah.
between, so thanks for answering first off. One thing that I'm very excited about is, on a clinical and epidemiological level, to understand what are these mechanisms between vascular disease, female hormones, and how does it work? And we really need to focus on it. And does it been done sufficiently in the past? So that is really something that should happen. And of course, I told you I'm a pharmacologist, so response to drugs is important for me. And one direction that we are going on now, and that I'm really, really excited about, is that we are able to culture blood vessels from individual patients via induced pluripotent stem
wow.
cells. So
Huh.
yeah, we are still working on the technique, but in principle, we can culture a blood vessel if we get just a blood vessel or some skin biopsy from a patient. And this will enable us to really focus on research that's in depth in pharmacology, real pharmacology. You can investigate receptor characteristics between patients with a good response and a bad response to drugs, and with and without side effects. So I think this will also teach us a lot more about individualized medicine, because we have drugs that work well on root level, but there are still patients with a good response, patients with worse response. And I think one of the challenges is now, why does a certain drug work in a patient and why not? And what can we do to improve the efficacy and safety?
Oh yeah, that's could really be, in terms of both understanding mechanisms and developing treatments, that being able to convert fibroblasts from a patient into blood vessels or neurons. I guess you could even get the neurovascular unit
Yeah.
in these preparations. Yeah, that'll be really interesting. That's something I would. I started out, and a lot of our work was in cell culture. So, and it proved very valuable actually over the many decades we.
Yeah.
Okay, thank both of you. I really enjoyed this. I felt really worked out well. It was a joy to meet both of you, and I learned a lot. I hope everyone listening and viewing found this both informative and maybe even something they can use if they happen to have migraine or cluster headache.
Yeah.
Thank you.
Okay.
Thank you.
Yep. Bye.
Bye-bye.
Bye bye.